Well, I'm a dermatologist at the University of Washington, and I also work with Dr. Shustaf in a clinic at the Seattle Cancer Care Alliance. So I'm going to kind of give you my perspective on sort of the first half. A lot of what we do, this mirrors what we do in clinic a lot of times, where patients with skin disease will come see a dermatologist and will have a big part in making the diagnosis, giving some initial information, and then if necessary, pass you off to an oncologist. So we're going to talk a little bit today about the overview of cutaneous lymphoma, emphasizing some things about diagnosis. And obviously you've already been through that, but I want to see if I can, as a dermatopathologist and a dermatologist, explain to you some of the reasoning behind some of the tests you might have had done or may have in the future. Talk a little bit about staging and then prognosis. Explain a little bit of our multidisciplinary care model. I think this is really important in skin lymphoma. And then we're going to divide up some discussion of therapies. So just another plug for the Cutaneous Lymphoma Foundation, because probably one of the first things that you and your family did when you heard about this diagnosis was go on the internet, and that's what people do these days, and we know that that happens, and we do it too. And you see these pictures, people with very advanced disease, tumors, deformed, and just, really things that are really striking and hard to look at. Talks about feeling sick, and you're going to lose your hair, and you're going to go through chemotherapy, and I think it can be a really frightening thing to see initially. And so the first thing that I do, a lot of the times when I will see a patient, is I'll ask them, what have you already read about this? What have you learned about this? And I'll try to redirect people to this website. I can't really emphasize enough how good it is, because it's really accurate information. I think it's vetted by physicians, but it's described in patient terms, and it's a great website. So thank you for all the efforts that have been done there. So skin lymphoma are classified as non-Hodgkin's lymphoma, as you all know, and the skin is a really common site for involvement of extranodal Hodgkin's lymphoma, and overall incidence is very rare, 1 in 100,000 patients. So, for your average dermatologist, they might see, 2 to 5 cases in their career. So that's why it can be difficult to diagnose. Cutaneous T-cell lymphoma in general is a lot more common than cutaneous B-cell lymphoma, so this talk will be a little biased towards that, but we will mention some cutaneous B-cell lymphomas. So to get on with cutaneous T-cell lymphomas, there are lots of different types, and I'm sure you might find yourself on this. I'm sorry about the small type. Luckily for us as clinicians, very few of these come commonly. Mycosis fungoides, or initial MF there, is really the most common type and really takes up about half. Anaplastic large cell lymphoma and lymphomatrid papulosis are lumped together because they can look very similar clinically, and it's the second most common, although I will say that a lot of physicians and scientists don't know whether lymphomatrid papulosis is really a lymphoma. So really this is very biased towards mycosis fungoides. Sézary syndrome is something that we see quite frequently too, and peripheral T-cell lymphoma is kind of not otherwise specified, makes up a good portion as well. So this is a typical presentation for early mycosis fungoides. This is, a typical patient we might see in a dermatologist's office. People come in with sort of thin patches and plaques, can look a lot like eczema. Sometimes the skin looks very thin, scaly. It's often on the covered sites. A lot of times people don't even know it's there because it's, maybe on your backside. Sometimes it can be very subtle, presenting just with color changes. And, if you didn't have itching and you just had color changes, you might not even think this was anything to worry about. Sometimes you can have bumps that come together into thicker patches. Later, people can develop tumors, sometimes really dramatic ones, and people can become red all over. So there's really just a really wide range of what people can look like, what can show up on your skin. So the other half of my life is I'm a skin pathologist. So when you get your skin biopsies done, it gets usually sent to a special skin pathologist who's either a pathologist or a dermatologist trained to read pathology. And that's half of what I do, and I really enjoy doing it. But I think it kind of helps me to understand when I see somebody, what is their biopsy going to show? Is it worth doing a biopsy? And under the microscope, skin lymphoma, particularly mycosis fungoides, has some terms that you might have heard and read about, so I thought it might be nice to go through some of this. So under the microscope, the top layer here, that's your epidermis, that's the top layer of skin. On top of that is the stratum corneum, that's what's sort of shed into the environment day to day when your skin is turned over. And then underneath this pink area is the supporting connective tissue, the dermis. And in mycosis fungoides, cutaneous T-cell lymphoma, the top layer, the epidermis, is thickened. And that's part of why the skin patches are thicker. And they're thickened because there are too many of these blue dots. The blue dots are lymphocytes, the T cells in this case, that come into the skin. And you might have read on your pathology report about a cerebriform cell, and that's just a particular kind of T cell that has a sort of wrinkled raisin or brain-like look under the microscope. That's what cerebriform means. And that's a hallmark of mycosis fungoides. You might have also heard about epidermotropism, and that's when the cells are attracted to the skin. Normally, we have lots of T cells and lymphocytes in our skin, but in cutaneous T-cell lymphoma, there are too many, and they clump together and they make little collections. And those are called microabscesses. It's not going to work. Oh, okay. But in these microabscesses, you see these little collections here. The other thing people will talk about is something called tagging, and that's where these lymphocytes kind of collect along the edge. You can see just a little dancing along the sides there. So those are all things that we don't see in normal skin. You might see one or two of those features here and there, but having them all together is helpful to make the diagnosis of cutaneous T-cell lymphoma. Once we've made a diagnosis, then we would go through the process of staging someone. These guidelines are really unique to cutaneous T-cell lymphoma and skin lymphoma in general. And it's really weighted towards knowing how much skin involvement. So the degree of skin involvement really biases your stage a lot, and that's very different than other types of lymphoma. So we divide it into how much skin involvement there is, that's the T, how much, if there is any lymph node involvement, that's N, and then whether there's any other organ involvement, liver, spleen, that's M, and then whether there's blood involvement. And there's a few things that can happen along the course to some patients that can significantly upstage you, meaning bump your stage up further. We divide this kind of generally into early and advanced disease, with stage 1 and early stage 2 being early disease, and stage 2B and higher being sort of more advanced disease. And the few things that really bump you up are the development of tumors, the development of erythroderma, so head to toe redness, and then the development of blood involvement, and as well as lymph nodes. So the prognosis of cutaneous T-cell lymphoma and MF has been delineated. There was, many of you may have been referred this study, and this is a landmark study that was done at Stanford on over 500 patients, and you've just heard that this is a really rare disease, so this is a pretty big study, taking so many people together and just following what happens to people. And this is an extremely helpful study that we use to tell people, here's what you might expect. And in this study, the one thing to notice is the probability on the left of surviving, and then the over years. And I think it's important to think that the time here is in decades. So this is, this goes out to 35 years. That's not true for a lot of cancers. I mean, when you put these types of survival charts up in some other cancers, that's in months. We're talking decades here. So that's a really nice thing to note first. The other thing, on the right-hand side, there are indicators of stage. There's a lot more people in early stages, and that's just how this fell out. It's just more common to have early stage disease, stage 1A and 1B. And also that those lines are flatter. So stage 1 and B are early patch stage. The majority of people start there, and the majority of people stay there. Not true for everyone. But those curves are very flat. What's the 5-year survival? A lot of people hear and read about these numbers, and they want to know that, what are my chances at 5 years? They're really good with early disease. We actually quote people close to 100% 5-year survival for stage 1A. That's the thinnest patch plaque disease. 95% if you have a little more skin involvement, more than 10%. It does get worse if you have development of tumors, and then if you're head to toe red, that's also a little worse. Another question we could ask a lot is, how likely am I to progress? Okay, I'm stage 1A right now. You said I have a good chance, but is that going to change? And this chart addresses that. This is your risk of progression at 20 years. 20 years, keep that in mind. So for stage T1 disease, which is less than 10% of skin involved, there's only a 16% chance that at 20 years you're going to progress past your original stage. So hitting the jackpot, I mean, that is a good way to describe it, because those odds are low. How about if you have a little more skin involvement, the chance of progressing is a little higher, 40%. And then if you have tumors or head to toe redness, that chance does go up quite a bit to 80%. So I'm going to switch and talk a little bit about B-cell lymphomas, which are less common. So I just have a couple things to say about those. Are there any questions about the things so far? No, okay. So B-cell lymphoma is less common, and there are really three main types that we talk about. There is marginal zone lymphoma, follicular sentinel lymphoma, and diffuse large cell lymphoma B-type. And I'm going to tell you that follicular sentinel lymphoma is a lot more common than the other subtypes. It really makes up the majority of what we see, with marginal zone lymphoma being the next most common, and then the leg type being the least common. We talk about there being lumpers and splitters, and I'm a lumper. That means I'm someone who kind of likes to put information in umbrella categories and not divide it up into too many details, and that helps me categorize things in my brain. When I think about these B-cell lymphomas, I think of them as indolent types, which is what most people have, marginal zone and follicular sentinel lymphoma, and then intermediate types. There really isn't an advanced type of cutaneous B-cell lymphoma, and that's the leg type, is the more intermediate. What do people look like when they develop these? They look all kind of similar depending on where they are in your body, but most of the time people have shiny, purplish to reddish bumps and tumors, often multiple, but can be just one. Follicle sentinel lymphoma tends to affect older people more frequently. It's usually on the head and neck, and oftentimes can be just a single lump like this, or it can be a bunch of small ones together. Marginal zone lymphoma often affects younger people, 20s and 30s even, and frequently just one or two. And upper arm, central trunk, head and neck are also common sites for that. The leg type lymphoma is the least common, and that's the one that's a little bit more intermediate grade, and so we're glad it's not as common. Tends to affect elderly people over 70 with nodules and tumors, and it has leg type in the name, but it doesn't have to be on the leg, and that's a pitfall for us as clinicians, that sometimes we can forget that. It can show up as a single bump like that thing, or lots of clustered, like on this patient. And it's helpful when I think about these indolent and more advanced ones, because the indolent ones really have an excellent survival. So if someone is diagnosed with one of these, we can tell them at 5 years, 95, 99% chance this is not going to alter your life at all. Whereas with the leg type, it's significantly worse at 50%. Okay, so how do we diagnose skin lymphomas? Well, you've all been through this, and there's lots of steps for it. There's obviously a good history, getting a good physical exam, dermatologists and oncologists sometimes. Lots of biopsies. You've probably most experienced that you think, well, I got a biopsy, how come nobody knows what's going on? We tell people sometimes that it can take up to 7 to 10 biopsies to make the right diagnosis, and I'll tell you a little bit why that might be in a minute. Now, blood tests might play a role. You might get some imaging, and then sometimes a bone marrow, sometimes a lymph node biopsy, sometimes other organs. So I just said it could take lots of biopsies. Why is that? Why can't we figure out what's going on from the beginning? Why is it so hard to diagnose early disease? And this is a schematic of the skin. So that pink layer on the top is the epidermis, and then the bottom layer is the connective tissue, and the red circles are the lymphoma cells. So this would be early disease, where there's just some lymphoma cells sprinkled around. There's a couple in the top layer of skin. But these green cells here, these are our normal, good immune cells that are coming in and keeping the lymphoma cells in check. So they're in balance. So in early disease, if you take a biopsy of this, you actually mostly see your normal normal healthy immune cells that are coming in. So, you know, they don't hold up signs and say, I'm fighting cancer. They look like normal cells. And so we might not be able to see the lymphoma cells in early biopsies. A little bit later on, when you get into thicker patches, you know, maybe there's more of the lymphoma cells. It's a little easier to tell. And then if you move on further to tumors, then you really get a, you know, larger nodule of them, then we can almost always tell. But at that point too, it's usually easier to just look at a patient and say, well, there's clearly something, you know, going on here. The International Society for Cutaneous Lymphoma has tried to address this difficulty in making these diagnoses by offering us these criteria. And they divide them into clinical features, so what someone looks like when you look at them on physical exam, where are their skin lesions, how long have they been there for, what do their biopsies show, histopathologic features, and you'll see that you can add up points, and if it's over 4 points, and that's suggestive of the diagnosis. So this is very weighted towards, you know, basic stuff that we do, skin exam and basic skin biopsies. I'm going to tell you about fancy studies that we do too, but I'll also say that diagnosing early disease, those studies are helpful, but they don't make the diagnosis. You know, you only get a point if you get this gene rearrangement study, and you only get a point for immunohistochemical studies. So those things are not be-all, end-all. We don't have the one study yet that says this is skin lymphoma. And that's a frustrating thing as a patient to come in and say, you know, this is something, I know it is. And it's frustrating as physicians to be able to say, you're right, but I can't tell you that right now. So I want to just take a few minutes to talk about some of these special studies. And the first are to talk about immunohistochemical stains or markers. You might read or hear about that. My skin lymphoma has, you know, the CD30 marker. What does that mean? And then also talk about DNA-based or molecular studies that we're using more and more now. The first is gene rearrangement or clonality studies, and then flow cytometry. So this is an example of a T cell. And you could insert a B cell very easily in the same schematic, but all immune cells in our body have lots of molecules on the surface. This T cell happens to have CD2, CD4, and CD3, and those are just basically address labels that label this as a T cell, tell it where to go in our body, and help it communicate with other immune cells. So this is kind of like its signature, this combination of things on its surface. It also has the TCR, which is the T cell receptor. And we can actually assay for these different molecules. We can do studies to look for those. And so when you get a skin biopsy and your doctor tells you your stains show that your tumor has CD3, what does that mean? That means that they've taken an antibody and they've put it in your skin sample, and it's bound onto this CD3 molecule, and then they've taken another antibody and they've labeled that antibody so that there's basically a pigment that they can detect. So this is what that would look like. On the left, this is just a histology section. All the blue dots are lymphocytes. And then on the right, that's with an antibody marking, in this case, CD30. So all those cells that are brown are CD30 positive. And that's all that means when someone says your skin biopsy was CD3 positive. That just means that they did a stain for it and it stained that. Any questions about that? This is like what I do half of my day, so I'm kind of passionate about this stuff. Molecular studies are kind of up and coming. You probably had one or both of these done, and I think they're really complex studies. They have a really good role, but I think they're hard to explain to people, and they're hard to understand, to read about them even as physicians. But what's a gene rearrangement study? It's also called a clonality study. So normally, day-to-day our immune system is waiting to respond to infections, waiting to surveil against cancer, and we have lots of different B and T cells hanging out just ready to do that. So, you know, for example, this blue cell was waiting for a staph infection, the green cell is waiting to attack prostate cancer. They're just sitting in wait. In the setting of lymphoma or any type of cancer, really, what can happen is that one of these cells starts to divide and it predominates. So in this case, that red cell is taking over. There's still some other ones in there, but there's a lot more of one particular type. And we can look for that because all of those immune cells still have all these molecules on their surface, in particular, in this case, the T cell receptor. So we can actually look at their T cell receptor and say each T cell receptor is unique to each T cell. So we can say, are there lots of T cell receptors that recognize prostate cancer, or are they all mixed up still? And what you get is a report like this, and you get, they'll say there's a clonal T cell population in your biopsy. So on the far right, that blue spike, that just represents a single clone of T cells that they saw. They say all these T cells have the same T cell receptor, and that's a positive study. So when someone does that study, that's all that means. And you'll note something else on this biopsy. They say at the bottom, we saw a T cell clone. These results could support a diagnosis of cutaneous T-cell lymphoma. T cell clones can be observed in some reactive conditions. Clinical and histologic correlation is required. So that's just a way of saying that, yeah, we had a positive study, but it doesn't mean that that makes a diagnosis, and usually your physician will tell you that too. Flow cytometry is kind of the newest kid on the block, and this can be done on skin, it can be done on blood, it can be done on lymph nodes. And basically what happens is you take whatever tissue, it gets ground up, and they divide it up into individual cells, and they make it into a liquid. And they put it into this machine called the flow cytometer. And now you have individual immune cells, that's the blue and the red guys there, and they shoot a laser at it. They've already taken those immune cells and they've reacted them with different antibodies. So they've taken things like the anti-CD2 antibody, the anti-CD3 antibody. Those are the molecules they said that are on the surface of all the cells. And when this laser hits them in a certain way, they get scattered. And then they measure how scattered are they. And different amounts of scatter correlate with different antibody binding on the surface. So you might get a report that looks like this, even more complicated. But basically, this person had all these different antibodies tested for, CD45, CD7, CD8, and they can say, you know what, this population of cells, this T cells in this patient, has too much CD8, and that's abnormal. Questions about that? Yeah.
Does the information that you're giving us now relate in any way to determining whether or not someone is a good stem cell donor?
No,
Okay.
not necessarily, no. That's a good question, though, yeah. I want to just take a minute, too, and talk about why we like to do this multidisciplinary clinic, Dr. Shustaf and I. You know, a lot of the times what happens is you might have seen a dermatologist, you might have seen an oncologist, and then they refer you to the other one, and then they refer you to yet a third physician. The diagnosis of skin lymphoma is extremely difficult to make, as you've all experienced, and as I've reiterated here. It takes a bunch of different people, and the treatment is just as complicated. You need a dermatologist to help make the diagnosis, to help sometimes control your skin symptoms. You need an oncologist to prescribe the chemotherapy if necessary. You need your pathologist to make the diagnosis, look at your skin biopsies. Sometimes you need a radiation oncologist. All those people are required for the care of a skin lymphoma patient. So this Yun Kim, who's you might have seen this slide before, but she is a dermatologist at Stanford who runs a big multidisciplinary clinic, and I did a mentorship with her, and she told me, the one thing you need to do to save time is to get your kids to help you make PowerPoint presentations. And so this is her 11-year-old kid, and I actually took away all the animation because it was so over the top amazing. But this is her example. You know, you might show up as a patient here, you're upset because something's going on, no one's telling you what's going on. You go to the dermatologist, they say, well, I think this could be it, but you better go see the oncologist. And then the oncologist says, I don't know, maybe go see the radiation oncologist, we probably need to radiate that. And everybody's calling the pathologist, what's going on? What's up with this biopsy? Well, wouldn't it be easier just to go to one place and see everybody all at once? And that's what we're trying the model we're trying to emulate. So, you know, you're here, people have told you have eczema, you have Sézary, maybe it's a drug rash, I don't know. You know, if we can all get in a room and meet together, you know, we can, a lot easier to make a right diagnosis. So that's what we're hoping to do. And here's our team. We've got some nurses, Kelly, Amy, and Beatrice, that's me, and then one of our study coordinators, Dr. Shustaf, and then one of our nurse practitioners we work with. So I hope that I haven't overwhelmed you with information. I hope you found something useful that you can think about, tell your family about. Yeah.
Because you're a pathologist and a dermatologist.
Yeah.
When a patient comes to you, are you their pathologist?
I'm not. I happen to practice in a different practice, but there are people who do that, and I think that can be really helpful. There's downsides too, because sometimes you're really invested in what's going on with your patient, and you maybe don't want them to have something. It can be, you might be a little biased when you look at their skin pathology, so there's reasons not to do that too. But there's a real reason to do it as well, because I've seen what the skin looks like. I can see what it looks like under this microscope, so it can be helpful too. Other questions? Okay, I think we're going to talk a little bit about treatment for early disease, unless there's other. Well, sorry. They tell you not to sneak those into talks, so I just put it on my desktop. So I'm going to spend a few minutes talking about therapies, skin-directed therapies that I as a dermatologist prescribe, and also a few oral therapies that I manage. And I think there's some principles in treating skin lymphoma that I like to think about every time I prescribe a medicine. One of my mentors, Dr. John Olerud at the university, always tells us, fit the punishment to the crime. If someone has very serious disease, then use serious medicines. But if it, is a less aggressive disease, then don't make somebody sick with your treatments. That's very, very important, and that's a principle that we use a lot in skin lymphoma. We have to weigh the risks with the benefits. Often, our goal in treating skin lymphoma is to control them, not necessarily cure them. Someday we hope that we can, but we're not there now. And so what we want to do is give you a good quality of life. We want you to be able to live your life normally without being embarrassed or feeling lots of symptoms. But in that, we know that recurrences are common. We want to, as much as we can, stimulate your immune system to help you fight the cancer early, and then use things to knock everything down later if we have to. And we want to encourage people to get into clinical trials if they're available to you. That's really important for us to learn more about these diseases, and they can be, life-altering treatments, and in a way you're helping other patients as well. So the National Comprehensive Cancer Network helped us really a lot in 2010 when they put together these guidelines for diagnosing and treating skin lymphoma, and they included them in the non-Hodgkin's lymphoma. So before, what was happening is, we'd see a patient, we'd say, I think you need this, and then we'd prescribe it, and their insurance would say, no, there's no evidence for using that. There's only one study out there. That medicine is too expensive. And we would say, well, you know what, that this is what we think is right, and we would write letters, and we'd call people. Having these guidelines in place has been really instrumental in saying, you know what, other people agree this is the right thing to do, even though the studies aren't out there yet. This is the standard of practice. This is what we want to do. Helps us enormously. And the Fred Hutch is included, and Seattle Cancer Care Alliance are included in this network. Just a few terms that I'm going to talk about. The way we measure responses in cancer in general, but including cutaneous lymphoma. We talk about CRs, which I wish we saw all the time, but they're complete responses. That means someone's skin disease completely went away, their symptoms completely went away. We talk about partial responses, which is oftentimes for patients actually good enough. If your itch is 75% better and your skin disease is 75% better, you can get on with your life, and that's oftentimes what we're trying to achieve. And then ORR is the overall response rate. A thing to think about when looking at studies or when I'm talking about this different treatments is that more effective isn't always better for you. So there may be a treatment with a complete response rate of 100%, but the toxicity is really, really high and makes people sick. So that might not be the thing you want for your skin disease. This is straight out of these guidelines. It's a list of recommended treatments, and I'm not intending to tell you about all of them or make you read it all, but the point of this is that a lot of these therapies are skin-directed. So a good half of this is for early disease in particular. What are you going to put on your skin to help help this. And a lot of dermatologists manage a lot of these things, most of these things. There are systemic therapies that we play a role in as well, and I'm going to talk about a couple of those. And then the rest of it is Dr. Shustov territory. So treating cutaneous T-cell lymphoma, this is also from Young Kim, just an overall, what could I expect if my disease did progress? And I will say that skin-directed therapies play a role for almost everybody, almost the entire time. And that's this top thing. 1A, 1B, those are the stages of disease, and then different therapies are listed underneath. Skin-directed and clinical trials, you'll see also, are something that we try to encourage, even in early disease. Exploring is when available, is when appropriate for me. And then we save other combination chemotherapies, transplant for very severe disease. So I'm going to talk a little bit about topical steroids, mainstay of therapy for almost any type of skin lymphoma. A little bit about nitrogen mustard, Imiquimod, which we use sometimes, Bexarotene Gel, phototherapy, and radiation therapy. All of these things, I think, are primary treatment for early disease, but really play a role for any stage. So topical steroids, your dermatologist gives you a big tub of stuff and says, put this on. Why are they doing that? Don't they know it's greasy and messy and ruins all your clothes? The reason we do this is because these things are not only there to moisturize your skin and make your itch a little better, they actually can cause the death of tumor cells, steroids. So they're effective for stage 1A, 1B disease, up to 80% response rate, so that's really good for a topical ointment. A very high effectiveness ratio to cost, so they're very effective for the price, one of the cheapest things that we prescribe. But it's messy, dermatologist is going to give you an ointment because they work better, and we know that it's going to ruin your clothes and your sheets, and they can cause skin thinning if they're overused, and if you use them on your whole body, you can absorb some of them, so there can be internal side effects. We sometimes will use them with something called a sauna suit, which is where we ask you to grease up from head to toe, and then you put this tracksuit on to make them absorb better and work better. And just a couple photos of someone who has done that. So this person, this is before treatment, lots of crusting, lots of redness, and then all we did was give him topical steroids for 2 weeks. It's still there, but it's quite a bit better, and that's just 2 weeks of an ointment. Skin-directed therapy with topical nitrogen mustard. I consider this topical chemotherapy. And nitrogen mustard, we've had a lot of difficulty getting it. We're no longer doing sneaking the vial home in the brown paper bag and painting it on you, although sometimes we did that at the Veterans Hospital. Now we at least have a pharmacy who will put it into some ointment for us, and so you can put it on that way. And we are able to get it back at the university again, which is great. This is also pretty effective, complete response rate in 60% of those with early disease. It can be helpful to bring out spots that are going to come later, so you can sort of be proactive and treat things that might be coming. But slow onset, you might need to use this 6 months to a year in order to get improvement. About 10% of people develop an allergy to the medicine. Messy because it's in an ointment again. There may be a slight risk of skin cancer down the road, although that's a risk with a few of our treatments. And then you can get dilated blood vessels or telangiectasias with some of these. And they're kind of expensive. A 1 pound jar at this pharmacy that we were ordering it from is about $700, so that's not cheap. Bexarotene or Bexarotene Gel is a topical rexinoid. The retinoids and rexinoids are all derivatives of vitamin A. So kind of stems from a natural therapy. And these also induce death of tumor cells, so they kill cancer cells. And unfortunately, not as great as we want it to be, but very effective for some patients, complete response rate of 20%, and partial response rate of about 40%. So, that's something that we turn to on occasion. A lot of patients have irritation with the treatment. That's very common with this whole class of medicines. You can get itching and burning, things like that, and it's quite expensive. Imiquimod, or Aldera, is a cream that I use sometimes. It is a medicine that's designed to stimulate the immune system. causes death of tumor cells by actually harnessing your own immune system to come in and kill the cancer cells. It was originally used by dermatologists to treat warts and precancers, and someone thought, let's see what happens when we put it on someone with skin lymphoma, and it turns out it can help. And they're very safe. The downsides are not FDA approved, and that's an issue because sometimes we can't get insurance to pay for it, although it is listed on those guidelines I told you about earlier, and that's been helpful. Can only be used in small areas, and that's because it comes in these little tiny packets, and then it says on the packet it's only used once. It can be frustrating and confusing. It can be irritating. Putting it on, you can get redness, and the treatment, again, can take a while. Can be really effective, though. This is a patient who has patches of cutaneous T-cell lymphoma on both buttocks. They only put the Imiquimod on that circled area, and this is, I think it was after 3 months of treatment. I'm going to talk a little bit about light therapy. Narrowband UVB is a type of, we call it medical tanning, that we use, that we might turn to when someone has spots that are a little more widespread, too much to put cream and ointment on, areas they can't reach. Well tolerated, it's safe. We've looked at the risks of developing skin cancer with using narrowband UVB in psoriasis patients, and it's very, very low. So we feel like it's a safe thing to prescribe. And this is what a light booth looks like. You would just go in and stand there for a prescribed amount of time. It does take time, though. You have to go somewhere where these things are, or maybe you can get one at home, but it takes up a whole bunch of space in your house. You can't get everywhere because you can't, expose everything all at once. There's going to be spots that don't get exposed to the light treatment, and then it also can be expensive because you have to do pretty frequent treatments. PUVA is a variant on light therapy that was mentioned earlier. Psoralins are compounds that are found in foods, so like celery and limes contain a lot of psoralins. And we don't make you eat a bunch of those before you do it. We give you a pill that has it. Can be effective for widespread spots, again, because it's light therapy all over. And what you do is you take a psoralin tablet, and then you go into the light box later after the psoralin has gone everywhere in your body and sensitized you. And it's a little more effective than narrowband, so if someone has thicker spots, it penetrates deeper in the skin. So the overall response rate is 40 to 60% for early cutaneous T-cell lymphoma. Downsides, sometimes you can get itching. The psoralin can make you a little nauseated. Again, you can't necessarily get to all the spots that are covered. You can get lots of sun damage because this is a more potent treatment, and there is a risk of skin cancer that's measurable. We know that if someone does more than about 150 treatments, their risk of skin cancer is going to go up. And then after 350 treatments, which, if you did it 3 times a week, is going to take you a few years, but you could get there, the risk goes up substantially. Radiation has been mentioned also, and we turn to this a lot. Very helpful for thicker plaques and tumors. Very effective. There's like a 100% response rate. Good cosmetic outcomes most of the time. And this is a diagram of what electron beam is, and we use electron beam a lot in skin lymphoma because it's a type of radiation that doesn't go very deep into the body. So if this is a skin disease, we don't want to radiate your heart and lungs. We just want to get to the skin, and this is a specially designed type of radiation to do that. That's very effective at the same time. Just a few issues with it, though. You have to be close to somewhere where they have this available. So you have to drive to a center that you can get it. So that takes time. Post-radiation issues, people can lose hair in spots, their sweating decreases, there can be obvious issues with that, and then it's expensive. But very effective. Here's a few examples of someone with a larger tumor near the eye. She couldn't open her eye, but after radiation, basically resolved. She did lose her eyelashes, and that's been bothersome, but happy in the end. A large tumor on the cheek, basically gone. So very effective. We don't currently have the ability to do head-to-toe radiation in Seattle, but we refer a lot to Stanford for that. Are there any questions about I've talked about so far? Lots of variable stuff you may or may not have tried. I'm going to talk about just a couple pills. We like to reserve systemic therapy when someone has either widespread disease or they start to develop tumors. So we don't tend to do this when people have thin patches and plaques or no blood involvement or anything like that. And one of the principles in designing treatments, or how do we pick which medicine when? And one of the principles is that we want to, as much as we can, use your own immune system to help us. We can cure almost any cancer for at least a short term by giving you really aggressive chemotherapy, and that almost always will get rid of it, but it will make you very sick. And we might not be able to recover from that. And so we want to not necessarily do that in the beginning. Your normal immune system is often there helping out, and so we want to boost that whenever we can. And there's two components that we want to encourage. One of them is called the cytotoxic T cell. That's part of your immune system that goes in and is surveilling around, finding things to attack. That's a T cell. And then the other one's called the dendritic cell, and these are like the Hoover vacuums of the immune system. They come in and eat things up. And cytotoxic T cells come in and they cause cancer cells to die. They kill them in a controlled way. And then these dendritic cells, the Hoover vacuums, they clean up the tumor cells after they're dead. And then they go on and tell everybody, hey, I just killed a cancer cell, let's go kill some more. And we want to stimulate both of those. And there's a couple treatments that we use that do these things. There are pro-apoptotic agents, so things that encourage cell death of cancer cells. And they do that by stimulating those cytotoxic T cells. Things like photopheresis do that, Bexarotene, which I'll mention. PUVA does it, electron beam radiation therapy. And then there are other things that stimulate the Hoover vacuums, interferons and Imiquimod. And so we often will try and combine these things to boost both sides of that. So interferon, Bexarotene, PUVA, photopheresis, these are things that we really try to use as much as we can in early disease. They're in general well tolerated. They don't suppress your immune system. In fact, they boost it up. Interferon, these are compounds that are named that because they interfere with infections in cancer. We use these in later stage disease. They're injections, so you have to do shots at home. People, because they interfere with infections, one of the things they do is make you feel like you have the flu, at least early on. And they can also stimulate your immune system too much. You can develop autoimmunity. You can start to attack yourself, your immune system. It's also extremely expensive. Bexarotene or targretin is a pill that causes the killing of tumor cells by stimulating your immune system. You can combine this with other agents. I often will combine it with interferon when I can. By itself has an overall response rate of 45%, but causes a lot of side effects, as every drug does. You never get a drug for free. We haven't yet designed the one drug that does what it's supposed to do without any side effects. Predictably causes people's thyroids to get out of whack, makes their cholesterol, their particularly triglycerides, which are the fats in your blood, go up, can inflame your liver, and this is also expensive. That's a running theme for a lot of the medications. We use a lot of these together, so we might do interferon and PUVA, and we can take the response rate from either one of these and boost it up, not necessarily adding the two together, but in general better. We can do interferon and Bexarotene. We can do interferon, Bexarotene, and photopheresis. Another class of medicines that Dr. Shustaf's going to talk a little bit more about, but is the histone deacetylase inhibitors. This is a relatively new class of anti-cancer cells that are designed to alter the ability of tumor cells to divide. And what are histone deacetylases? That you're going to have to step back to think about that before you can understand what these drugs do. Their normal role is to turn off and on the reading of DNA, and that's about as far as I understand about them. The way I think about them is that normally we have cells in our body that are, it's kind of like turning on a computer. You want your cells to be on and ready to go when you tell them to go, but you don't want them sitting there accessing the internet and buying things online without you telling them, right? Then that's kind of what a cancer cell is doing. It's doing things without being in check. It's not under control. So normally these histone deacetylase inhibitors are keeping them, awake but asleep. But cancer cells, when they don't have these histone deacetylase inhibitors there, are on all the time. They're just, partying at night, they're wasting your battery, and they're burning out the screen. So they're stuck in the on state. There's two of these that we use in cutaneous T-cell lymphoma. They've used in a lot of other cancers too. One of them is Vorinostat, that's a pill that I'll mention briefly, and then the other one's romidepsin that Dr. Shustaf's going to talk about. These are both FDA approved for advanced cutaneous T-cell lymphoma. And the definition of advanced for the FDA purposes is that you've tried a few other therapies first. Doesn't necessarily mean that you have, stage 4 disease. And these drugs are exciting because these are some of the first few drugs that have been designed and approved just to treat skin lymphoma. I mean, that's a big deal. Vorinostat has some side effects, fatigue, so feeling pretty tired. Patients who I have had on it have said, I didn't really notice that I was tired until I stopped it, and then I realized that I had been tired, like really tired, just kind of that feeling like you've been out running around all day and just have a little bit of that all day. Sometimes nausea, not very common, but frequently diarrhea. They have an overall response rate of about 30%. So it's not great, but it's not bad either. And, just a word about when you hear about response rates for a particular drug, remember that that is a statistic. That's if you treat 100 people, 30% are going to respond. That doesn't really mean anything for you as a person. You're not going to respond 30%. It's going to be yes, it works, or no, it doesn't. It doesn't mean that you shouldn't try something because it has a low response rate. And these drugs are nice. We talk about them like chemo-light. So they are chemotherapy, technically speaking, but they're not going to make you sick in general. I'm going to talk just a little bit about the treatment of cutaneous B-cell lymphoma, and this will be the end of this portion. And nicely for cutaneous B-cell lymphoma, people tend to have fewer lesions, so they're a little bit easier to treat. Remember that first chart I showed you, was just full of text. There aren't as many things on this. And that's because radiation is really, really effective for this. When people have just a few spots, we tend to do radiation. It works, done with it. It may come back, and we can just do radiation again. Independent of the type of treatment, about 40 or 50% of people will have another spot at some point in their course. We also will use observation, so we might just watch it. We might just say, you know what, you're going to survive from this whether we treat it or not. If it doesn't bother you, it doesn't bother us. Let's just leave it alone. That's a reasonable thing to do. We can inject it with steroid medicines. When someone has spots, in a more widespread fashion, again, we might just watch it. We might give them a systemic treatment, like rituximab that Dr. Shustov would prescribe. So just to sum up this portion, we try to fit the punishment to the crime. So, when you're hearing about the different therapies, you're reading about them all online, and you think, well, why didn't my doctor choose this one that's much more effective? The studies say it's 60%, and you're giving me a 30%. It's because we want to fit our punishment to the crime. More effective doesn't necessarily mean the right drug for you. Any questions about that stuff? Okay, I'm going to turn it over. Yeah.
My only comment now.
Please.
The good thing is switch fast
Yeah.
on a lot of these. And we had a great doctor out in New Hampshire who was willing to do that.
Mm-hmm.
We probably have 4 or 5 of those that we went through. And it's just nice knowing that there are so many options out
Yes.
there. Sometimes, it's scary if that was the only thing and it didn't work. So
Exactly.
It's nice to have
Mm-hmm.
stuff.
Yeah. The other thing about skin lymphoma that's different than other types of lymphoma is if you use a treatment and it works for you, and then later it doesn't work for you, and you switch to something else and that doesn't work for you, you can still go back and use that first thing again. In other kinds of cancer, especially other lymphomas, once you use a treatment, it doesn't work, you're done with it. You can't go back. You just have to keep going up, 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 up. The treatments get more and more and more serious. Skin lymphoma, you can go right back to that topical steroid if that worked for you, and that's nice because it keeps your options wide.